Good afternoon and good morning to everyone, and thank you for joining us for the final day of the 2021 Healthcare Project Delivery Conference. On Tuesday next week, we will be sending out an email with a link to the presentations from the conference, as well as a survey. So please take 5 minutes and let us know what you thought, you liked, and where you think we could improve. We really like to hear from you, our community. We have another fantastic day of programming for you today, including an opening plenary with senior representatives from Indiana University Health, LA County of Public Works, UCSF Medical Center, and the University of Utah Healthcare, which I'll introduce in just a minute. And our closing session this afternoon is a moderated discussion hosted by Johnson Controls with representatives from OSHPD, California's unique regulatory body, the Office of Statewide Planning and Development, the University of California, Irvine, and co-architects, who will discuss how the model can apply to other jurisdictions also facing issues of climate resilience. Today is also the last day to visit the Expo Hall during the live event and learn about our sponsors and exhibitors, and to hunt for the final 3 hospitals hidden at the booths. Happy hunting. I would now like to introduce Barbara Wagner, who is joining us again this year. Barbara is an executive vice president with Clark Construction Group, one of the largest general contractors in the country. Barbara has over 35 years of experience in construction and began her career on the East Coast managing public and private construction projects in my neighborhood in Washington, D.C. and in the Boston markets. Since 2002, Barbara has lived in Los Angeles, where she leads Clark's National Healthcare Center of Excellence. For the past 2 decades, healthcare clients throughout California and across the country have relied on her expertise for the successful planning and execution of their renovation, expansion, and new construction projects. Barbara participates on several boards, is the past chair of the National Design Build Institute of America, and she serves as president emeritus of DBIA's Western Pacific region. Barbara, thank you for joining us, and over to you.
Thank you, Jennifer. I think we can all agree that 2020 has been a challenging year, like no other, and has brought a host of new challenges to the healthcare industry. So we've learned quite a bit over the past year, many lessons which can be applied today, and really how we look to the future of healthcare. So clearly there's a lot to talk about. I'd like to turn it over to the 4 panelists to self-introduce themselves. Hoda.
Good morning, everybody. Thank you for having me. I'm Hoda El Sokari. I'm a Senior Capital Project Manager with LA County Public Works.
Sorry, I guess James.
Okay. Good morning from California. Good afternoon for those in other parts of the country. My name is James Pease, and I'm the Executive Director of Health Design and Construction for the University of California, San Francisco.
Rod.
Good morning. I'm Rod Randall from the University of Utah Healthcare. I'm the Senior Construction Manager here, and I oversee the design and construction of our projects.
And Loretta.
And I'm going to say good afternoon in my time zone, everyone. Loretta Sherwood, Director of Integrated Project Delivery, Indiana University Health.
Thank you. I think what you'll find today is our panelists really all bring a unique perspective to the discussion. So we'll explore from these experts on really what's on the top of their mind, what issues are they seeing in the industry in response to COVID-19, and really how lessons learned from the past year have influenced their future projects. One of the lessons learned from the pandemic is clearly the critical need for the hospitals to remain operational. So first, I'd like to have each of the panelists discuss some of the broad impacts of COVID-19 on their healthcare facility design and construction. And I would like also each of you to discuss some of the challenges and shortcomings you've encountered over this past year. I think we'll start with Hoda. Hoda, you're on mute.
Oh, I apologize for that. Over the past year, we had several projects in construction in an existing and operating facility, one of the county facilities. And at the onset of the pandemic, it was the stay-home order, and even though we kept construction going, but the design team wasn't able to come into the job site and address RFIs and unforeseen conditions that we encountered. And even though the contractor tried to do its best with taking pictures and describing what the issues are, but still we couldn't get the issues resolved, and we had to, become innovative. And we decided to hire a third-party contractor to do a 3D scan for the above ceiling existing conditions and provide that to the design team so they can look at the existing conditions as if they were on site and start addressing the RFIs. We also had other issues with laborers testing positive for COVID. One of the plumbers, for instance, tested positive, and everybody who in his crew was in contact with him, they had to stay home. So we had all of a sudden the entire plumbing crew not being on site. So we had to work around that and rearrange the work around it. In addition to maintaining social distance within a confined workspace. So we had to rearrange again the work schedule to work around that. So it was learning on the go. As we were working, we were trying to reinvent ourselves all the time to come around those challenges.
Rod, Loretta, James. Go ahead, Rod.
I think we had some similar stuff, but we also had some unique challenges. We brought on a new hospital, an expansion right before the pandemic hit, which actually helped with the influx of patients. But then we also brought on a new rehab hospital, the Craig H. Nelson Hospital, during the pandemic, which was also a challenge. It was interesting to see two hospitals open up, just a few months apart, and the differences between the open house. One had thousands of people, and one was a virtual one. But I think we've seen a lot of the same things: remote working, hybrid schedules, splitting staff, so they weren't all in the same location at the same time, so we could maintain social distancing and guidelines. So a lot of the same stuff kind of Hoda talked about.
I operate from the operations planning, transition planning side of the efforts, and we have several projects in flight as COVID came in last year, and our biggest, adaptation, flexibility, and constantly pulse checking as we go has been the name of the entire year. What we had to originally do is just kind of pause because, our partners, our operational partners, they just had to have all of their mental and physical energy be focused on how do they adapt to their surge, how do they adapt their spaces, their team, etc. to that. So our instruction was like, wherever you were in this project, whether you're developing their workflows or helping them with developing their training plans or whatever, try to keep the work flowing from our side as far as like developing drafts for them to react to, where previously maybe our model was working collaboratively to create. And then as the months progressed, it was not just kind of go to the back, kind of like move away from interacting. Then it was, okay, let's do some small amounts of interacting, not at the same pace or the same frequency that it was pre-COVID. And so then that was in little bits and pieces. Then whenever another surge would occur, it was, okay, back away. So we've just constantly been trying to continue to move our projects along and the work efforts to the plan, but always adapting, especially from our operations side, to what the demands were for operations. And I just know by being in partnership with all of my construction team, is also adapting in the several ways, like Hoda was expressing, that it's just, can we get into the space and, what materials are lagging behind, or who's sick on the work site, and et cetera, how to access the work site.
I'll just add a couple of things that weren't said. A lot of the same things. We had a push, which I'm sure all did, to create additional capacity that we weren't used to. So we ended up putting up tents in the parking lot for patient care, which you've seen a lot of. That's definitely not something we had done before. It's not something the regulators in California were used to doing. So I would say we actually worked with OSHPD and CDPH closer than ever, and really, sounds bad to say, but it was really a lot of fun, actually. There was a tremendous amount of collaboration and work going. We actually we have a hospital that we haven't been using for several years, but the beds are still licensed. In California, they're in suspense. And so we reopened a hospital that we hadn't been using with 53 beds. And we didn't have an active kitchen over there. So all of a sudden we're building a kitchen on an emergency basis. We're setting up tents, trying to figure out how to deal with patient and visitor screening and employee screening. And I'm sure as others had, we had a big drop in elective surgery volume. So we did have a big revenue hit. We only funded about half of the capital projects that we thought we were going to fund. But that seems to be behind us, and we're back at a frenetic pace. We shut down. San Francisco, more than other areas, shut down pretty quickly. I think they did a good job. So we shut down about 20 construction projects for 6 weeks, and then figured out how to start them back up again. And now figuring out how to vaccinate our PMs, and then spreading that out to the contractors and people working in the facilities is kind of all of that on top of a typical year of just madly trying to deliver projects and operating facilities. That's what we've been doing.
And I would like to add to James, really a shout out to OSHPD. They have been really a partner during this pandemic. We worked very closely with them. I had the first project approved within amazing time with OSHPD. So thank you for them very much.
Something I didn't realize with OSHPD as well is they end up playing a lead role in the wildfires. So they really had two massive public health emergencies that they were dealing with at the same time over that summer period last year.
Yeah, wow, that's amazing. I didn't know that either. As Jennifer, I'm just going to put a note that there is a closing session with OSHPD for today. So for those that may be interested in learning more, they can attend that session at the closing. I'm going to switch it around a little bit, because clearly we've been talking about how we've learned to work with social distancing and how we had to do things differently in order to handle these surges. So during the pandemic, we also saw a need because of the speed to market solutions, whether it was adaptive reuse of hotels, convention centers, semi-permanent structures and tents, as James had mentioned. I know for our company, we actually adapted a prison in Maryland, and then also a hospital that had been shuttered a couple of years ago in order to handle some of the surge. But so clearly in healthcare, we've been seeing over the last several years a great interest among clients in some form of alternative delivery model, really to accelerate their projects as a speed to market strategy. So if possible, I'd like all four of you to comment on your procurement delivery model and how it has really benefited your program. I'll start with James.
Okay, so I work for the University of California, which is I would say it's like a quasi-government agency. So in general, we follow the public contracting code. I spent much of my career in private healthcare delivery and was able to use integrated project delivery and a lot of flexibility in contracting. It's not the same with the public contracting code. So really learning where I think it's more challenging, it's hard to get trade partners and contractors on board really early in the design process. It's hard to have more of a target value design type process where you can get a lot of cost input during design and you can study a lot of options. So honestly, our team right now, almost everything we deliver is design, bid, build. Almost everything finishes late. Almost everything finishes over budget. So we're looking at progressive design build and really just getting trades on earlier. That's been the goal to the team. Is I really don't mind which model you use, just get trades on, get input from construction during early design. And then our largest project, which I'm not directly responsible for, we actually got approval from the Regents of the University of California to use a true poly-party integrated project delivery contract. So with luck, that will become a case study that other public agencies can use in the future to say, see, this also works.
Oda?
So, as a government agency, like James just pointed out, we have to abide by the public contract code. So, in public works, we use design build, design bid build, and job order contracts. And we became very innovative in terms of combining two delivery methods within the same project, like using JOC, for instance, which is a job order contractors, to do what we call make-ready projects for a design build project. So within an existing facility, for instance, we can use JOC for doing underground utility duct bank, for instance, or the backbone structure for a fire alarm system. And that happens simultaneously while we're procuring the design builder. So that way we can address any unforeseen conditions and minimize change orders when we get the design builder on board. But also, by the time we have the design builder contracted, we already have completed a substantial amount of the work that we were concerned about. We've been also trying to get the design builder to do investigations during the bidding or the Part B after they get shortlisted. We allow them to actually go into the facility and do their thorough investigations in return to a stipend that also includes their efforts to provide any documentations or presentations or renderings for the project. So we've been very successful with that model, the combination of JOC and design build, and we've been able to complete projects ahead of schedule and below budget that way. So,
thanks, Oda. Clearly, we've been seeing a lot more of design build, progressive design build here in California. Rod, would you like to comment on what you use at University of Utah?
Yeah, so we do bring on our contractors as early as we can while we're still working through our design process to help with estimating and constructability questions and concerns we may have throughout that process. So that's been our typical practice on all of our big projects. Some of the small ones we do just hard bid out. But I think in part of the question is the adaptability. So I mentioned kind of earlier that we built a new hospital. Well, when we moved the unit over, we were supposed to remodel a floor. Well, the pandemic hit, right? And so the adaptability is let's refurbish this. Let's make the necessary changes we need to. And so I think that flexibility in the design process is a big piece. as we've adapted kind of through the pandemic.
Good point. Loretta?
We are doing a mix of all types. I mentioned earlier that I'm clinical by nature. I work on the side of the operations planning. So what we are saying that we deliver, our methodology is integrated delivery. The industry recognition of IPD or integrated delivery has that connotation with the integrated form of agreement. Our focus on integrated delivery is partnering with the stakeholders and the users through the entire life cycle of the project. And so our kind of tagline is that we're really working on delivering patient care. We don't deliver physical facilities, we're delivering care environments. And that's our integrated approach. So sorry for that plug, but to answer your question pointedly we're still working on all strategies.
Thanks, Loretta. I'm curious for anyone to comment in terms of talking about delivery is, since you've clearly been moving to, again, more integrated teams, and I assume they're probably awarded on some sort of best value platform. Have you seen the benefits of bringing in the designer and the contractor in early? Clearly, since healthcare does involve a multitude of stakeholders, and there are so many critical elements of getting it right in terms of the design and looking at constructability issues, et cetera. Anybody want to comment any further on that? No?
I would say in California, in a 70-year-old hospital, it is the only way to get it done anywhere close to reliably.
I'll tag on to what I said just a few moments ago. We say that our integrated approach, our integrated process is built on a lean foundation, and so really understanding that A3 thinking. Who are the right people to get at a table? What is it we're actually solving? How are we going to measure success? And that parallels very closely with the process of project development and conceptualization. So we definitely get people in a virtual room now, but get them in a room, get everybody understanding all those things that I named. And I think that goes a long way with the relationship building to have some of those key conversations as we go down the life cycle.
I can kind of chime in too. I think a lot of what James and Loretta are saying are 100% true, and that benefits us as well. It helps to have everyone at the table to understand, if we could have the world in this, what is it we want? And with the contractor on board, we can, if we need to, we can value engineer things out and make sure we're kind of staying on budget. So the value of having the team all at the table at once that's going to deliver this project at the end, from the consultants to the contractor to the subs, I think is crucial and has been helped in our success for sure.
Thanks, everybody. Hoda.
Yeah, I just wanted to add that since the Public Works Department started doing design build, it's been a learning process for us, because when we first started, we were doing like 100% DD plans as scoping documents, and then as we moved along, we realized that this is not really serving the purpose of design build, and we started to cut back to just maybe program or SD, depending on the type of the project and the system that we're trying to deliver, and trying to bring the contractor and the design builder early on and have their expertise chime in along with the users, and have these meetings where everybody is on board and have the users' input, the contractors' input, and also us as owner reps.
Yeah, good point, Hoda. I mean, clearly bringing in the design builder or the contractor in early is allowing for more innovation as you're working through the design. And as James had mentioned, the importance of bringing in some of those key trade partners like MEP, drywall, and really when you're to ensure that the documents, especially for those of us in California, and getting them permitted and making sure that they're constructible is very important, just like anywhere in the country. So I'm going to switch gears a little bit and talk a little bit about some of the healthcare current trends and how they may have been accelerated by the pandemic. So clearly over the last several years, we've seen clearly a focus on standardization, flexibility, resiliency, and providing essential care services. So one question I have for the group here is, what's really been the impact to your organization and capital programs? Are you looking, especially in light of the pandemic, easily adaptable spaces in order to remain versatile to meet future pandemic needs? I mean, I totally realize we're not going to go out there and build a pandemic hospital, right? That doesn't make sense. It's doesn't happen every year, hopefully not. But again, having something that's more resilient, more flexible, more adaptable. So who would like to start? Rod.
I can start us off on this one. I think, the flexibility is crucial in a few different ways. A couple of things we're doing here at the University of Utah is we've looked at the flexibility when we vacated one floor that we were going to remodel, and I was telling you about, we ended up putting patients in there. We're looking more at flexibility of, the difference between an ICU or acute care units and how they can kind of go back and forth. And so we have that flexibility, obviously, with the COVID-19 surges at times. ICUs were tight. They were a struggle, at least for us. There wasn't enough capacity. So having flex units that can adapt between ICU and acute care is one of the major things. Another one is with our HVAC systems, and can we isolate a floor? So we had a shelled space on the building we completed, and so that's one of the things we're looking at now as we build out a new inpatient unit. What are the flexibilities in the HVAC system and isolating rooms? So we have AIIR rooms or isolation rooms, but also so that we have isolation from other floors. So if we need to make a floor isolated from the others, and they don't run through the same HVAC system.
Any other thoughts, Loretta?
I think that we've all talked the past couple of days in the conference, and we all know that there's lots of conversations about workspaces and hybrid workspaces as we begin to have the conversation of like who can continue to work effectively from a virtual platform, who needs to be on site at certain times, and so hoteling spaces. Or other components versus designated seating spaces. But I think beyond that conversation, I think there's the next layer of who needs to be in a healthcare space. So as we're thinking about the hospital and designing a hospital space where we used to program in a lot of offices or seating spaces, it's like, if it's not about patient care, let's get that in another space. Let's get that in another platform. So you see those kind of conversations arising in that. And I think there's also not just COVID-based, but I think there's a maximizing space of, does every location need a waiting area? Like, how can we leverage all of our square footage more effectively rather than having lots of waiting areas or different things like that?
So I would just add on, I don't know that it changes our core healthcare strategy, and that our focus is kind of a teaching hospital and a research institution. Is we're really focused on complex care where people need to be in the hospital. Definitely our video visits, like I'm sure everyone's have gone through the roof. I would say the silver lining for us at San Francisco is a very tight real estate market, or at least it was 6 months ago. And all of a sudden there are opportunities for space because we were competing with Google and Facebook. And I'm still here. I'll fix the camera. Google and Facebook for space. And they've all now decided they don't need the space that they had. And we now have some opportunity to decompress our campuses and keep only the healthcare and the research that's patient focused on the campus. And then, like everyone, we will never have as many people in roles that don't need to be on campus. They're not coming back, at least not the way they were before. So I'm done.
So from the county perspective, most of our facilities are really older facilities. In addition to the new campuses that are still in the programming phase. So we need to make sure that those facilities are resilient and can address any drastic events, whether pandemic or, like in California, earthquakes. And this is what we've been really focused on, that we need to provide these emergency backups, power, sewer, water for all facilities to make them resilient. And we're already working on that. We're currently installing a third generator, 2 megawatt generator at the Olive View Medical Facility that will provide complete redundancy for the hospital in case of power outage. The other thing also, everybody's been talking about hybrid and telehealth, but our county facilities also serve like the underprivileged communities where not everybody has internet or even a computer at home. So that's another thing that the county is also working simultaneously to make sure that we have the digital infrastructure first, so everybody would have internet. As well as working also on providing these advanced telehealth care in our county facilities.
Thanks, Hoda. I mean, we could do a whole session talking about the impacts of telehealth, and where we go from here. But in the interest of time, I think we're at 9:32. I have one final question. We actually have a question from the audience. So the question is, building and facility are costly and time-consuming to build. Have you had discussion with care providers that allows care to be provided in less ideal environments? Military has been using MASH tents in the past. Would this be even possible in today's care environment? And it's from Henry Cho with AE7. Anybody want to comment?
I can start us off again, if that's all right.
Sure, Rod.
We did set up, for lack of a better term, MASH tents. We still have some actually set up as we vaccinate some of our patients. We have a facility that's older and small, and we don't have an area to observe them 15 minutes after they get their vaccine. There's just not an area big enough to host, 50 people at a time, socially distanced. So we've set up one of our their Blue Med tents out at the site, and so we've seen that a lot. We've also used tents for bringing people in and kind of doing a check before they enter the facility, before they enter the ED. We haven't really had inpatient units by any means stay out in these tents, but we have utilized tents to help with capacity and to keep people spread out and socially distanced.
Thanks. Totally agree.
The same here. The tent usage was definitely there. We had care being provided in EMS vehicles, when the tents were full. And so one of the other couple of great things, just like we've talked about this disruptive force that has pushed this technology evolution and paradigm and pushed the telemedicine paradigm far beyond. I think another thing is just like I said, being able to make quickly adapting auditoriums or conference spaces into care spaces. Whenever the infusions came about a few months back, we took actually a closed, like an aged conference center, and we adapted that in 5 working days into an infusion clinic. And it was amazing to see how quickly, whenever you kind of get out of the paradigm of structure and checking all the boxes, how fast you can make things happen. And so I think it was just amazing to see that it's about yesterday, and I think the fireside chat or one of the sessions, I hate that I'm recording it and can't give credit, the physician from Dr. It's care. Ultimately we're wanting to provide care, and we let all this other stuff get in the way. And so I think that this is absolutely going to continue to this question, help us understand that it's not about a physical environment, it's about care. And how can that be provided wherever it's at, and how, in whatever platform.
Thanks, Loretta. I'm going to finish it up with the last question, and there's actually a few questions from the audience that I think really wrap into our final question. So let me just address the final question. So I wanted to end the session with each panelist addressing their unique perspective for 2021 and beyond, really the next maybe 1 to 3 years. So what does your organization anticipate for the future, and how you're primed to respond? Basically, really looking at what does the future look like. And a few of the questions from the audience really ties into this. One is from Travis with PDC Partners, is responding to Hoda's comment about generators. So what the panelists thought on building resiliency, right? So the idea that hospitals cannot fail. And then another question from Enrique Romero with Kleinfelder is, with limited space and not knowing what the future holds, how much focus will there be on new developments versus repurposing buildings and space? So we're seeing a lot of that too in terms of the repurposing. So if all 4 of you, I'll start with Loretta. All 4 of you can comment on really what does the future look like for your organization? And then maybe if there's anything with these 2 questions that you can address in your response. Loretta?
We're at the beginning of the design phase, transitioning from programming to design phases for a very large new hospital in our system. And we've got guiding principles that really reflect what our conference has restated repeatedly. And they were actually established, before COVID, but their adaptability, resiliency, transformation. We have to recognize, I think one of the lessons this is teaching us is the space that we have, whether it's built now or we're building it, it needs to adapt. It needs to flex. And so making sure that our longevity of our facilities, whether they're 50 or 70 years or 100 years, that we program in that flexibility that we've had to really exercise on overload in this past year. I think another statement that was in the past 2 days was, again, care being provided in the hospital. We need to recognize that care is moving into more of that community focus. And so we need to be ahead of that as we continue to think about our healthcare facility planning.
Thanks, Loretta. Rod?
Great. It's a great question and a great combo of questions. We had an interesting perspective here in Utah. A few weeks into the pandemic, we had an earthquake, a 5.7 here in Salt Lake. So to answer the question, are we looking at other things? Yeah. What's our power supply coming to our hospital? We're fed from 2 different substations. We have a generator backup. We now are finishing up a project where we have generators that back up our generators that are on trailers that will help with our ICU units. So those are some of the things I think we're doing to respond to this pandemic, and then also the earthquake that kind of happened to us right after the pandemic kind of started. But I think we're also looking at things, I think James alluded to this earlier, as capital was kind of reduced. We delayed some of our capital projects, mostly because of funding, and we didn't know the impact at the beginning of the pandemic. But now we're starting to see those things come back together, and we're starting to really pick up steam on our projects and get going. So it's hard to say exactly where we're headed, because I think we know, but I'm sure we'll pivot like most of you and adapt as time goes on.
Thanks, Rod. James?
So briefly, I think kind of resiliency is kind of the name of the game in California hospitals. So I think that's something we're definitely investing in. We have about a $10 billion 10-year plan, because the average time to just get approval and build a hospital in California is about a decade. And so we have some big projects we're working on. I was chuckling when you said 1 to 3 years. Our next 1 to 3 years are delivering the projects that we funded 2 years ago. And, anything new that we're thinking is at least, 2 to 3, 4 years out from now. One comment about the reuse, we would like to reuse more, but old hospitals are too small. They don't meet, the corridors are small, the air capacity is small. So with all of the, new patient care standards don't fit in old patient rooms. So everything is either a full gut remodel or a new, and with accessibility, which I'm completely supportive of. But the second with this, when you expand a bathroom in a patient room to meet access, it bumps out of the room. So basically everything becomes a full gut remodel or a new building for us once you meet all the requirements. So, and that's why it costs $10 billion and we're not getting new beds. We're just replacing stuff.
Good point. Hoda?
So, like I said, our older facilities, we need to make sure that they are resilient until we have the funds to build new hospitals. So we have a $1.8 billion master plan for Harbor UCLA, and there is another master plan for LSU USC. But for other county facilities that they still don't have the fund allocated for them, we need to make sure that those hospitals will continue to provide its services until their service life. And that's what we've been working on. We've been working on the NPC 5 compliance for all older county facilities to provide those power, 96 hours of emergency power, water, and sewer. And we've already been working with OSHPD on that. Like James was just pointing out, it's in California. Things doesn't happen very fast. And within the existing hospitals, in order to remodel, we have to literally gut everything down and redo it. And we always get into the ADA compliance issues. So it's two paths in parallel, making sure that existing older facilities continue to provide its services under any circumstances, but also make sure that the newer and facilities that we're going to be building are going to be having the adaptability and flexibility of the future that's required for the future.
Thanks, Hoda. I think, when SB 1953 passed in California many years ago, and we were obligated to build for resiliency, that what we're doing here, we're going to start seeing based on what's happened with the pandemic through the rest of the country. So we're going to probably, when you're building for resiliency. So, and what it does actually to costs of rebuild or whether you can renovate, whatever. I mean, it's just an additional challenge. So this is, it's been a great discussion. I really would like to thank each of the panelists today for their time, really bringing their unique perspective as to some of the challenges posed by the pandemic and what it's meant for them and their organization. So thank you. I appreciate your time today. Thanks.
Thank you. Thanks, everybody.
Thank you.
Thanks.